Dr.Sivaprasath.
Good morning and welcome to you all. A very warm, happy Sunday of learning. We have covered almost 17 sessions till now from January, and it has benefited a whole range of postgraduates from final year to first year. So as you all know, you all have been recently joined, and the way they start your curriculum is you have to go through history of anesthesia. Only if you know the past, you will have a bright future. And likewise, the second topic is on the breadwinner of anesthesia, that is spinal anesthesia. These two topics are covered by doyens in anesthesia. The first one is Selvakumar sir, and the other one is Edward Johnson sir. Both are very fierce teachers. So welcome Selvakumar sir and Edward sir. Selvakumar sir he's been my teacher since he's teaching for a very long time. And 2 generations of anesthesia he has created now. And sir is the HOD of Madurai Medical College. He's been an active member in ISA, past president, secretary, and I think no conference is complete without sir's speeches, and especially his history is so lucid that you will hear it like a story from him. So we are waiting for that. Let me go into the topic. Welcome, Selvakumar sir.
Thank you, Siva. Good morning, Edward. My dear colleagues and friends and my dear students. You have entered into anesthesia curriculum, and I welcome you with the so-called boring topic. People may think that history is boring, but it is not so. So only when you know the history, problem. Next slide is not going. Yeah, only when you know the history, when you know about the past, the future will be bright, as Prasad correctly pointed out. History is never boring, especially our field, anesthesia. So to go into the history of anesthesia, we have to know about what has happened some 100 to 200 years back. Pain was accepted as a normal phenomenon. God has given the pain. So nobody should try to relieve it. That's why anesthesia has not developed those days. But if you think that pain, is it a blessing or a curse? People will try to think that pain is a curse, but it is not so. It is a blessing. Only when you have pain, then only animal can survive. The best example is leprosy. A toe affected by lepromatous leprosy, definitely the next day morning when he gets up, the rat will take away the toe. Without pain, he will not be able to save his limb, like that. So pain has to be there, but certain procedures in the body have to be performed unless otherwise the pain is tackled. But pain is a mysterious phenomenon. When the tolerance of pain is very high, especially when it is linked with religion or patient. The best example is this one. This fellow, does he not have any pain? Or this girl, so-called very sensitive area, does he not have pain? Definitely they'll have pain, but somehow they tolerate it. So, but from the days of Stone Age, we are trying to conquer the pain. That's how the anesthesia developed. So we all know that some 175, 180 years back, the first demonstration of painless surgery happened in America, Boston. Before that, we just want to know what they did before modern. So what has happened in the pre-era? So in those era, the surgery was an agony. Especially some 3 or 4 surgeries were performed very frequently. One, a mangled foot amputation, circumcision for religious reason, and burhole tapping, thinking that some bad omen has entered into your body. Putting a hole in the skull will make you disease-free. Something like that. Some 3 or 4 surgeries were performed and they were done like that. So many anesthetists were there, you can notice. And again, another thing is pain relief was often linked to the religion. So nobody has dared to attempt the pain relief. So anesthesia didn't develop at all. But there was a drug. there is a drug. Even now, it is the best drug as far as analgesia property is considered. So it has been ruling mankind for more than 4,000 years. Even now, that is considered as queen of analgesic. A beautiful flower, poppy flower. The liquid extract from that unripe fruit, unripe flower has to be taken out. That latex, it has to be dried, and alkaloids, morphine, thibine, and codeine were extracted. There is some interesting finding about morphine. It was used well even in 3400 BC. There was mentioning in the ancient literature. It was considered as a joy plant. And since it caused some froth, if it is consumed excessively, some probably pulmonary edema. So it was named as Ahifina, that is venomous froth. So even in Indian and the Greek literature, everything, Roman literature, everything it was mentioned about the morphine. It was mentioned as halgil, meaning a joy plant. So it was rather misused, but not medically used. So even Greek gods, they want to decorate their gods with the poppy flower. So poppy flower, poppy seeds and poppy flowers and poppy extract very, very popular. Even in 1500 BC, it was mentioned in Iberis Papyrus. That was one of the best books in the ancient time. He has suggested you can stop crying in a child using grains of poppy plant strained to a pulp. Very easy method. Then they started mixing, I don't know, I didn't go into the detail of ethyl alcohol. Ethyl alcohol started ruling all over the world, even now. Even the government has to run with ethyl alcohol. This chemical, how it came into the human civilization, but somehow they found ethyl alcohol with opium very powerfully relieving pain and producing euphoria. Mainly these drugs were used to cause euphoria. The side effect happened to be pain relief, and it was found accidentally. And the Sydenham considered that is the best gift given by the god. That even if you go through the Indian history, East India Company, which ruled India before independence, they grown poppy in so many parts of India. They cultivated it, they exported it to other country, and they earned a lot of money. So India was a place where opium was cultivated. Now it is made, it's banned. So after the opium, and another interesting plant is mandragora. So I just came through the literature, the very funny plant. There was a belief this plant has got tubers. And these tubers have to be buried out from the ground to pulp it and then consume it. It contains active alkaloids, atropine, scopolamine, and hyoscine. So some kind of euphoria was produced because of the consumption of this tuber. But problem is, there was a belief that if you dig out this tuber, it will start scream because the tubers resemble human siblings. So if you want to take it out from the ground, you have to tie it with your dogs on the other end. And if you run away, your dog will also try to come with you. At that time, that the tuber will be plucked out from the ground. And then the dog will hear the scream, it seems, and the dog will die. Those whoever hear the scream of that tuber, people will die, it seems. So they believe like that. So that's how it was being dug out, and these tubers resemble like a small human sibling. That's why they feared, but it was not so. Belief is like that. This clipping is taken from Harry Potter. Even it beautifully depicts this tubers. I have unmuted it, so you can just listen. You can see. Very interesting to know that even cinema people have known about this mandragora. And the term mandrake, if whoever has read about comic books, magician mandrake character is there. That mandrake is taken from this mandragora. It's nothing but scopolamine. So we all know that this atropine and scopolamine can produce euphoria and delirium. We have seen in OPC poisoning patients. So she just demonstrates, and they are wearing a scrambler just to not to hear the scream of the tuber. So that's how the imagination goes. Right. The next is cannabis. cannabis was misused or misused even now. The active alkaloids, the cannabinoids, tetrahydrocannabinol, the various parts of the plants, flower and leaves is called marijuana and hashish. They are all used now also, but rather they are all become illegal. Then the famous ubiquitous ethyl alcohol, it was tried to clear the pain associated with so many conditions medievally. So often it is mixed with other alkaloids, and we don't know when human civilization has started brewing ethyl alcohol, but even now it goes very strong. So as I said, these were all the surgeries performed those days. So the requirement of surgical field for anesthesia is very limited. Just to hold the patient, cut the prepuce. When the patient screams or getting fainted, nobody bothered. So in India also, they have attempted surgery even before Christ. As we all know, Shushruta started couching, cataract surgery. As I said, the main the hurdle in the development of anesthesia was because of religion. Because the Eve has listened to the serpent, and as she has ate the apple, then only she started having all the kinds of emotions, including pain. So God has to punish. He has listened to the serpent. So the pain is a punishment to the mankind. So God has given that pain. If you don't attempt to relieve the pain. But slowly the industrial revolution started taking place because of World War I and II. The industrial revolution, so many chemicals, cylinders, the metallurgy, so everything have to develop. So at that time, so many people started experimenting with many chemicals, and one of that is nitrous oxide. Nitrous oxide was found to be very interesting. So many people started doing so many experiments with nitrous oxide, and Humphrey Davy was one of the unfortunate person. He has ventured into nitrous oxide experiments, and even he found out that it possesses anesthetic property. Even he mentions, he writes, as nitrous oxide in its extensive operation appears capable of destroying physical pain, it may probably be used with advantage during surgical operation. That is with notes, but he missed it. He hasn't presented. So those days, so many lectures, some traveling lectures, they used to take place. They used to make fun out of it with so many chemicals. They mix acid and alkali, the fumes comes like that. In those lectures, they were using nitrous oxide as a laughing gas. They asked the audience to come to the stage, make them inhale nitrous oxide, and if the people become euphoric and started laughing, so people used to make fun out of it. So that's how even cartoons appeared on those days. It's a prescription for scolding wives, it seems. If they inhale, they become laughing, something like that. So nitrous oxide was used that way. Then the Horace Wells came into the picture. Horace Wells, he was practicing dentistry. He designed some dentures, but his business was not flourishing. So when he wanted to analyze it, he came to know that the pain associated with plucking of tooth, the dental extraction was excruciating, and so many people fainted. That because of that, so many, they don't come to the hospital at all. So he wanted to improve his practice. He was searching for some pain relieving procedure for dental extraction. At that time, he came across a traveling lecture like this, and he found out that the nitrous oxide can be a remedy for him. So he had the courage of extracting his own molar tooth under nitrous oxide. He brought nitrous oxide from the traveling fellow. He came to his clinic. He asked his assistant to plug his good tooth, healthy tooth, and he didn't find any pain. Probably he would have inhaled very nicely. So he thought he has found a miraculous drug. So that's how you all know that. Immediately he announced the surgeons in Boston, I'm ready with the drug. You can have it for the surgery. It will make the surgery painless. But unfortunately, he has selected a wrong drug. You all know that nitrous oxide is a very weak analgesic, and it has to be inhaled more than 100%, then only it can produce a 1 MAC. So what happened? The patient complained pain. So he was forced out of the theater, saying that it is a humbug. So after the debacle, a very unfortunate thing happened. He couldn't believe that he has failed. So he went around, he had a quarrel with one of the lady, he threw sulfuric acid over to the ladies, then he was present, then he committed suicide in the jail itself. Then that's why it is said, it is not the one who discovers matters, it is the one who convinces the world will win. That's how Martin did on 16th October 1846, a successful demonstration, but he has selected ether now instead of nitrous oxide. So 16th October is celebrated as World Anesthesia Day all over the world. Following the discovery of ether and successful surgery, but people are not happy with the ether. So all over the world, especially in Britain, people started searching for some other alternate drug. So one of the drug, and James Simpson, he used to try for so many drugs in his home, suggested by so many chemical friends. At that time, one fellow by name David Waldy, he suggested chloroform. Doctor, you can try this drug. So this is a famous dining table experiment in his house. The Simpson and his family, they inhaled the drug in the previous night, and next day morning they woke up under the table. The chloroform was so powerful, it knocked them out. So from that day onwards, we are called the chloroform doctors. And the tribute to Simpson is the first baby born to a mother who received chloroform for pain was named anesthesia. So coming into the next follow-up through the chloroform days, John Snow, a famous anesthetist, epidemiologist also, he introduced these kind of instruments for application in obstetric analgesia. Then that's how the general anesthesia started developing. On the next side, the local anesthesia, the Erythroxylum coco. This is a plant where the South American Aborigines, they used to chew for creating euphoria. So those days, those continuous chewers, they started developing many psychiatric problems. So Sigmund Freud, who was a father of psychiatry, he started investigating those people, why these people develop these psychiatric problems. Then he also tried some coca leaves and found out that it produces numbing of tongue. So it occurred to him that it can produce some anesthesia. So he suggested, his psychiatric man suggested Carl Kohler, his ophthalmic friend, because Carl Kohler was not happy with ether. When you give ether for an ophthalmic surgery, you know that the problem associated with vomiting, retching, the intraocular surgery, the problem with opening the eyeball will be a problematic one. So he was searching for some other drug which can produce an immobile eyeball and without any side effects. So when Sigmund Freud suggested this coca leaves can be crushed and these alkaloids can be used, when he tried, he was very happy. So he presented in the German Opthal conference, and that's how the cocaine was born. So Sigmund Freud, he never claimed, I have only suggested, so I should be the father of local anesthesia, because he is deemed to become very famous in psychiatry. So he didn't claim for it. So that's how the first, in 1884, local anesthesia was born. But nowadays, the cocaine is misused not for anesthesia as a snuff. Then the significant historical event which has happened is in the introduction of tobacco. This is a plant where it was used as an arrow poison in the South Americans. So they used to coat the arrow with this alkaloids of controdenton, and they used to store the alkaloids in either a tube or a pot. So that's why in the retrospective, if you see, it was named as tube tobacco, tea tobacco. So pot curare or tube curare they used to call. So they used to coat the alkaloid over the arrow and used to shoot the animals. Since it is not toxic when it is consumed, the animal will remain edible even after hunting. So when people started investigating what is and side by side, they demonstrated the neuromuscular junction, physiology, everything. Then with courage, Griffith and Johnson, they introduced this curare in the surgery, and they started controlling the ventilation. From that day onwards, the surgical development and anesthesia development has come to this era, because they were not able to open the cranium and also thorax without in patients in spontaneous ventilation. So only when the patients were made paralyzed, Then only surgery developed. So from that time onwards, see, we could enter into the major cavities, and we started acting as a messenger of God to relieve the pain of the mankind. And I hope the journey continues now. So that will, we are almost halfway through. We have finished one part of the history, and another one I wanted to tell you about this, how our Boyle's apparatus evolved. Day in and out we are using our Boyle's apparatus, and the name daily we are mentioning. Let us go through a brief history of Boyle's, how it developed. So he is a British man. So since we are all colonic countries, we started following the British methods. That's why we are following Boyle's. American countries, they used some other machines. Ohio, I think. So we are British colonial countries, all the countries we are using Boyle's. Even now it has changed into, the form has changed into many form, and no longer a Boyle's machine is found in our workstation. All the system is changed. So going through the history of Boyle's machine, you can see this was the anesthetic ornamentorium some 150 years back. Very simple, just like a tea filter. So it is not complicated. It has few bottles with some liquids, some for masks, that's all. Those days, it was considered as an art, that's all. How to make under a person without struggling, that's all. They used to pour chloroform, they used to pour ether, ethyl chloride, something like that. It was considered as an art rather than it is not based on any scientific method. Then you can see this is the first anesthetic equipment used by Martin, a bottle with the ether soaked sponge, that's all. And slowly it got developed one by one. Hager, he developed his inhaler. Likewise, Clover, an intelligent man. He only found that monitoring during anesthesia is very important. He showed the importance of monitoring the pulse. He is his father. The patient, what he has shown here is his father, just to demonstrate that the pulse has to be monitored during the surgery. This is his ether apparatus. So then Hewitt has developed for chloroform. He has developed an ingenious apparatus where exhalatory valve is designed very beautifully. That's how it works. Likewise, Junkers, he can push some air into the chloroform so that he can under the patient very easily. Slowly, one by one, as the need developed, those machines started developing. Magel, the famous Ivan Magel, he has developed his apparatus. Slowly, the stand started appearing. They want to fit some vaporizer. You can see a water bath is kept outside the ether bottle so that it can provide some heat buffer for the vaporization. That's how the Magel's apparatus worked. Then McKesson developed the intermittent flow for dental extraction, especially when the patient, he can inhale. Slowly, stand appeared in the design of machine. And side by side, the World War I, it necessitated the people to go for field anesthesia. So to give anesthesia in the field, the Oxford University has asked Epstein and McIntosh to develop an apparatus. That's how the EMO is developed. So war is interlinked with the development of our field. That's how with the bellows, we can give anesthesia. And I am fortunate enough to give anesthesia for 10 or 15 cases with this bellow. Air, ether, and relaxant. Even for upper abdominal surgery, we have given in 80s. So then the teeter apparatus, one by one, it started developing. Once the oxygen was filled in cylinder, because cylinder was developed those days, then the industrial development occurred. Then slowly people started filling the oxygen in a cylinder. So the cylinder has to be fit in the machine. Naturally, a stand has to be devised. Likewise, slowly stand came into the picture. The cylinder storage and the vaporization storage. Then the important development is cotton good apparatus, because the Boyle has visited US and he has seen this machine, this one and Watami machine. And he after seeing those machines, he came back to Britain and then he developed his own. He is a left-handed fellow. So he developed his machine that was called as the Boyle's machine. Till now it is being named. Then side by side circle absorbers started appearing because cyclopropane was introduced into the field. Cyclopropane was explosive and expensive. So people wanted to reuse it. So the need for developing a circle absorber came into the picture. So circle absorber was developed. And as you all know, the water canister, what does the develop this? It's a simple vaporizer, so sorry, simple absorber. The main advantage is the conservation of the heat and humidity with this. The main disadvantage, it is very close to the patient, the inhalation of the dust particles occur. And then Coxter is devised. Likewise, slowly the vials is shaped into the present day design. You can see a water bath over the ether vaporizer. And then this is one example of a vaporizer, ether vaporizer, where it is a measured and bubble through copper kettle vaporizer. You can see how many cylinders are fit. And color coding was not rampant on those days. It was not mandatory. This is a working principle of copper kettle. And then in America, Ohio, side by side, they developed. Since we follow the British system, we haven't followed much about American system, but Ohio has developed many interesting equipment in the anesthetic arena. So this is the vials apparatus in the 70s. You can see the ether bottle. Likewise, this is the this is a Mark III halogen vaporizer, and this is the ether vaporizer. You can see this is looking unique. The one bottle is ether vaporizer and one bottle is soda lime canister. So there is a VIC vaporizer inside circle is also there. Then coming to the 80s, trilene came into the picture, and the problem of trilene, you know, it is not compatible with soda lime. So they have to provide a lock. So this trilene vaporizer is linked with the common gas outlet, so that trilene cannot be given when closed circuit is on. So trilene lock was introduced into the vials apparatus. And then the pin index safety system. Slowly the problem started occurring by connecting the cylinders. So pin index was introduced in 1952. Likewise, this is a very beautiful valve devised by Heatbring, because those days spontaneous ventilation was in the order. Most of the time we don't paralyze. Even in our days, in 80s, we used to give spontaneous ventilation for so many ortho cases. So this valve played a major role in providing anesthesia. Just 1 minute ventilation is enough. A Magel circuit with a Heatbring valve. He devised it. And that's how the Heatbring valve works. A simple procedure, a simple design. And the vaporizers, once halogen came into the picture, it was very powerful, so and potent. So the vaporizer size decreased because it can anesthetize a person with a very compared to ether and chloroform. So even with 1 or 1.5%, it could anesthetize a person. So the vaporizer size reduced. This is a Goldman vaporizer. Even just 10 years back, it was used all over the our area, but slowly it is also being withdrawn by the developed vaporizers. And Tech series vaporizer came into the picture. Mark 1, Mark 2, just like Ambassador Mark 1, Mark 2. Slowly this is Mark 3. And from that time onwards, Mark 4, Mark 5, Mark 6, Mark 7. And each one has its advantage over the past one. And then so many systems have been introduced, interlocking system, filling system, the safety has improved. And still till now, the vaporizers start evolving, and so many new designs have come into the picture. The one thing I should not forget in the development of history is even some 10 years back, we used to see so many airway fatalities. We used to hear from our colleagues in the remote area, the peripheral area, even in the cities, the airway catastrophes without LMA, without Bougie and McCoy, so many catastrophes have occurred. We used to rush, we used to save, and we have lost patients because of airway problems. But after the introduction of this LMA, almost death has become nil because of airway. So this is his original design. So I should not forget in mentioning this. So that's how our machine and the anesthetic field has developed. Now it has come up to this. You don't find a flow meter. Everything is electronic, and you happen to be like a airline pilot, where all the controls and as the equipment is being added to the armamentarium, it becomes complicated also. And the pre-induction check must be perfect so that you land up in problem. That's how we developed from the handkerchief soaked with ether. From that time onwards, slowly we evolved and we have come to the stage of robotic surgery with anesthesia. So evolution is a part of any field, and anesthesia is not an exception. So that's how it's a brief glimpse. We cannot completely cover the history of anesthesia, especially the drugs, how they got developed, how when it was introduced. It's very difficult to cover. Even then, let me give a glimpse of history and the interesting part alone, so that all the youngsters, at least once you go through the history, the first 100 years of anesthesia, there is a book, a beautiful book. And the interesting part is how there is mentioning in that book about the entry of anesthesia in India also. Since India was a British India those days, the introduction of ether taken place 1 month after the introduction in America, in Britain. So in another month, October, it was introduced in America. In January, it was introduced in Calcutta. So Calcutta was the headquarters at that time. So the next hospital which used ether was Chennai, Madras Medical College. So many interesting things was mentioned in the book. Everybody, I advise you to go through that book. I thank the organizers of online anesthesia for giving me the opportunity. Hope it acts as just you to find out more history in the textbooks. Thank you, one and all.
Thank you very much, sir. That was a very enlightening lecture. And I hope all PGs will get the spark to read more about history in their books, sir. It is always interesting to read, especially the history in Wiley. We used to read it again and even now when I get chance, I read Wiley. So PGs should read it and they should get inspired from our predecessors who have done a lot for our field. Thank you very much, sir.
Sivakumar sir, please remain for the final discussion.
Yes, thank you. I hope there should not be any doubts regarding history. There should not be any doubt about history.
There is one query on what is the author of the book you just mentioned, sir.
I also forgotten. It is in our library, Madurai Medical College library. I can get it and put it in the online, the WhatsApp group.
Thank you, sir. Okay, let's go on to the session 2. It's a very interesting, exhaustive session on spinal anesthesia by our Edward Johnson, sir. Sir is a professor and HOD of Kanyakumari Medical College. He is the past president of Tamil Nadu ISA and has been an associate editor of IJA. He has presented many papers and editorial write-ups in many international journals. He has been awarded the ARC Education Initiative Award in 2017. We are eagerly waiting to hear from you, sir. Very detailed lecture on spinal anesthesia. Welcome, sir.
Thank you, sir. Thank you for your kind introduction. As you said, it is going to be an extensive topic because I have covered from anatomy, physiology to practical tips. So in my topic, I am going to cover the functional anatomy of spinal blockade, surface anatomy, pharmacology of local anesthetics, pharmacokinetics of local anesthetics, glass spine model, and technique of spinal puncture, and equipment for spinal anesthesia. So pharmacodynamics of spinal anesthesia, so management of hypotension after spinal anesthesia, and also finally the clinical situation encountered in our day-to-day practice. So it is going to be really a big topic. So regarding the history, Carl Kohler first used the cocaine for anesthetizing the cornea and conjunctiva, and followed by that, William Halsted and Richard Hall used to inject the cocaine into the tissues and nerves and produced localized anesthesia, and they have performed minor surgeries. And followed by that, James Leonard Koning is the first one who administered the cocaine in the spinal anesthesia, spinal canal. Then a short history about the CSF. A neurological fluid was first noted by Galen in the year AD 200, and CSF was later studied in 1500 by Antonio Valsalva, and Durapuncture was described in 1891 by Winter, and that was followed by 6 months later by Quincke. So August Carl Gustav Bayer in 1898 is the first person who demonstrated spinal anesthesia for himself. He administered spinal anesthesia for himself in his own house, in his guest house. He was not able to get up from the bed for 3 days because of the severe headache and giddiness, and he lied in the bed in the guest house, and his wife was searching for him for 3 days. And followed by that, his assistant, Dr. Otto, has accepted to administer spinal anesthesia for himself. And August Bayer has done a series of experiments on his assistant Otto. After giving spinal anesthesia, he hit his tibia with hammer, and he made incision on the thigh, and he also squeezed his scrotum, but Otto didn't feel any pain. And followed that, Tate and Coido have performed first spinal anesthesia in the United States in 1899, and Rudolf Matas is the first one who has given morphine in the spinal anesthesia. And Tuffier popularized spinal anesthesia in the Europe, and Gaston Labat popularized spinal anesthesia in the USA. So the wide publication of the spinal anesthesia come to a halt in the year 1947 after the report of widely published Woolley and Rowe case report in the United Kingdom. The Woolley and Rowe are the two patients who are admitted in the same hospital same day. They have undergone spinal anesthesia. Followed that spinal anesthesia, they have developed paraplegia. So most of the anesthetists thought it is due to the spinal anesthesia, but in the subsequent court of law, they have proved it is not due to the spinal anesthesia, but it is due to the contamination of phenol present in the spinal ampoule. So for a long period, the anesthetists are afraid to perform spinal anesthesia. But in year 1954, Trips and Van Dam described the safety of the spinal anesthesia. After that, spinal anesthesia became popular throughout the world. So the functional anatomy of spinal cord, Koning once stated in 1900 that I advise those who contemplate practicing spinal anesthesia to take a look at the skeleton, especially the lumbar vertebra. The intelligent glance of this sort will be more than many words. So let us have a look at the vertebral column. Vertebral column has a 4 curvatures, that is cervical, thoracic, lumbar, and sacral. The cervical and lumbar are convexity anteriorly, and your thoracic and sacral are convexity posteriorly. So these curvature, along with the varicity of the local anesthetics and gravity and patient position, determines the level of the spinal anesthesia. So there are 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. If we look at that anatomy of the lumbar vertebra, this is the body, this is the pedicle, this is the posterior spinous process, this is superior articular surface, this is inferior articular surface. So in between the two pedicles, there is a foramen called intervertebral foramen, through which the spinal nerves emerge on either side. So this is the posterior view of the vertebral bodies. So the inferior surface articulate with the superior articular surface of the lower vertebra. The space in between the two lamina is the interlaminar foramen, through which we are approaching the spinal anesthesia. So if you see the curvature, lumbar curvature, the third lumbar space is the highest, and the thoracic, the 5th thoracic vertebra is the lowest. So there are 5 ligaments. The first is the supraspinatus ligaments that connect the epiphysis of the spinous processes. It starts from the 7th vertebra to the sacrum. Then interspinous ligament, it connects the spinous process together, and posteriorly, that is yellow color, that is ligament of flavum, it connects the lamina above and below together. So in the posterior aspect, the anterior longitudinal ligament and posterior longitudinal ligament, they together connect the vertebral bodies in position. So the thickness of the ligament of flavum in lumbar region, it is 3 to 5 mm, and height is 15 to 16 mm, and width is 16 to 20 mm. So coming to the 3 membranes, so you know the dura mater, it's outermost. The dura sac extends to the 2nd sacral vertebra. The arachnoid membrane is the middle layer, and the subdural space lies between the dura mater and the arachnoid mater. The arachnoid mater ends like dura at the S2. So the pia mater, it is closely clinches to the spinal cord, and it ends as a phylum terminale, which helps to hold the spinal cord to the sacrum. So the space between the arachnoid and pia mater is known as the subarachnoid space. The spinal nerves travel through this space along with the CSF. So coming to this, length of the spinal cord varies according to the age. If you see in the first trimester, the spinal cord extends to the end of the spinal column. But at the fetus ages grows, So the vertebral column lengthens more than the spinal cord. So at birth, the spinal cord will be at the L3 and adult, it will be L1. So there are 8 cervical nerves, but only 7 cervical vertebrae. So the cervical spines 1 to 7 numbered according to the vertebral body below. So the 8th cervical vertebra exits below the 7th cervical vertebra. So after that, the spinal nerves are numbered according to the vertebral body above. So up to 7, it is numbered according to the vertebra below. And after that, it is numbered according to the vertebra above. So coming to this autonomic nervous system, the sympathetic nervous system is the thoracolumbar outflow and parasympathetic nervous system is the craniosacral outflow. We are more concerned with sympathetic nervous system. So I am going to talk about the sympathetic nervous system only. So it starts from the intermediate lateral column and lateral horns and exits through the anterior roots from T1 to T2 spinal nerves. So see, this is it exits through the anterior nerve root and goes to the parasympathetic ganglia, sympathetic ganglia. So the communication between the anterior nerve root and sympathetic ganglion, that is pre-sympathetic ganglion, is called white ramus communication, and post-sympathetic ganglion is called gray ramus communication. It goes and combined with the subsequent spinal nerves. So there are 3 cervical, 12 thoracic, 4 lumbar, and 5 sacral ganglia. Of these, only cervical ganglia are named as superior, middle, and inferior. The inferior cervical ganglia fuse with the first thoracic ganglia to form the stellate ganglia. So the neurotransmitter in the postganglionic sympathetic nervous system is the noradrenaline. It acts on the alpha 1 and alpha 2, beta 1, beta 2, and beta 3 receptors. So the main function of sympathetic nervous system is to maintain the tonicity of the blood vessels. So it maintains the blood pressure. But the only exception is the coronary vessels and skeletal muscle in external genitalia. When the sympathetic system is stimulated, there is a vasodilatation of the coronary vessels, skeletal muscles, and external genitalia. So coming to the surface anatomy, so the lower end of the scapula corresponds to the T7, and the highest iliac crest, the highest point of the iliac crest, if you connect both sides, it passes through the L4 or intervertebral disc of L4 and L5. It is called Tophius line. Then posterior iliac spine connects through the S2. So a dermatome, what do you mean by a dermatome? It is an area of sensory innervation by a sensory fibers from a single spinal nerve. So T10 dermatome corresponds to umbilicus, T6 corresponds to xiphoid, and T4 corresponds to the nipples. So these are the dermatomal level which is needed for each surgery. So upper abdominal surgery, you need a dermatal level of T4. For intestinal, gynecological, urological surgery, you need a level of T6. For TRP, you need a level of T10. For vaginal, T10. And for the lower leg, you need L1. For foot and ankle, you need a level of L2. And perineal and anal, you need S2 to S5, saddle block. So coming to the pharmacology of local anesthetics. So a brief pharmacology. There are 2 types of local anesthetics. It is amino esters and amino amides. The structure is the aromatic lipophilic portion and intermediate chain. Both are combined together by this amino amides or amino esters. You remember the amino amides means there are 2 I. So any drug that comes with 2 I, that is lidocaine, mepivacaine, prilocaine, bupivacaine, etidocaine, ropivacaine, levobubicaine, all comes with 2 I. So it belongs to the group of amino amides. Then amino esters, there is only 1 I. So the drugs cocaine, procaine, tetracaine, chlorprocaine, benzocaine, all comes with 1 I. So it corresponds to amino ester. It's an easy way to remember the group of each local anesthetics. So coming to the local anesthetics, how will you determine the potency of the local anesthetics? So the potency of the local anesthetics depends upon the lipid solubility. Low lipid solubility means low potency. So that drug need high concentration. For example, bupivacaine is a high lipid soluble, so it need a low concentration of 0.5%. But lidocaine compared to bupivacaine, it is a low lipid solubility, so it needs a high concentration of 2%. Likewise, the potency is determined. Then the duration depends upon the protein binding. Suppose the protein binding affects the duration. The higher the protein binding, longer the duration of the action. So bupivacaine has a high protein binding, it has a long duration of action. Then the onset depends upon the availability of the base form. So if here example is here, there is lidocaine, it has a pK value of 7.9. What do you mean by pK value? pK value means the pH at which the drug exists 50% in the unionized form and 50% in the ionized form. So for lignocaine in 7.9 pH, it exists 50% in the unionized form and 50% in ionized form. But in supply, it is supplied as pH 6. So 1% is in the unionized form, 99% in the ionized form. When you inject this drug into the tissues, in tissues there is a pH of 7.4. So 24% remains in the unionized form and 76% in ionized form. Remember, this unionized form only can cross the lipid membrane. So this crosses through the inside the cell. So inside the cell, the pH is 7.1. So 14% remains as the base form and 86% in the ionized form. You remember that only the ionized to act on the sodium channel from inside. So 86% it will act from the inside. So potency, depending upon the lipid solubility, tetracaine is a highly potent. Bupivacaine comes second, lidocaine, then mebucaine. Onset, the pK value. So the pK value is closer to the physiological pH, means more drugs will be in the unionized form. For lidocaine, it is 7.9, so it is close to the physiological pH compared to the bupivacaine, so it is quick onset. But if you see chlorprocaine, it is well away from the physiological pH. It is 8.7. Still, it is the quicker onset. How it is possible? Because by the high concentration of 2 to 3%, the pK effect is offset. So alkalization also speeds up the onset because it produces more unionized form. So pharmacokinetics of the local anesthetic or subarachnoid space. So once you deposited the local anesthetic in the subarachnoid space, so what is the fate of the local anesthetic in the subarachnoid space? So it is determined by the 4 factors, that is concentration of the local anesthetic in the CSF and surface area of contact of the nerve tissue exposed to the local anesthetic. So local anesthetics enters into the nerve tissues by way of diffusion. So there are some other pathways. They are called periarterial Virchow-Robin space. So through which the drugs are taken. This is the periorbital Virchow-Robin spaces. And third thing is lipid content of the nerve tissue. So if there is more lipid content, that is myelinated fibers, it will take more drugs. Likewise, the blood flow to the nerve tissue. If there is more blood flow, more drug will be eliminated quickly. That's why the local anesthetic is greater in the posterior spinal cord compared to the anterior spinal cord. This says the blood supply in the anterior spinal cord is high, so the drug concentration is low. But the posterior root of the spinal nerves are thicker than the anterior root. Still, they are more blocked than they are more susceptible than the anterior thin motor nerve. How is it possible? Because the posterior nerve root have a component of bundles. So they increases the surface area of contact of the local anesthetics. So more local anesthetics concentrated on the nerve tissues and the concentration is more on the posterior surface. So the posterior sensory nerves are more susceptible than the anterior motor nerves. So coming to this more controversial topic, that is differential sensory block. That is the order of susceptibility of the nerve fibers to the local anesthetics. So different books says different nerves susceptibility. So first we will know what is the nerves. The nerves available are classified as A, B, C. A is myelinated, B is myelinated, C is unmyelinated. So A alpha is proprioception and motor. A beta is touch and pressure. A gamma is motor spindle. A delta is temperature, that is cold temperature and short pain. B is myelinated, it forms the preganglionic sympathetic fibers. This is the most sensitive susceptibility. No. The C is unmyelinated, it's a controversial fiber. It transmits dull pain, temperature, that is warmth, and sympathetic postganglionic. So if you take this 9th edition of Miller, it says B is more susceptible than C, that is followed by A delta, A beta, A alpha. But Kurtz's pharmacology 13th edition, the susceptibility is in the range of B and C susceptibility is same, followed by A fibers. But Ganam physiology 23rd edition says C is more susceptible than B than A. But this figure is taken from the Hustic manual. Here the susceptibility order is BAC. So it is completely different from other books. So the author Hustic says the myelinated fibers are more susceptible than the unmyelinated fibers because in myelinated fibers, the local anesthetics gets pulled near the axons, so they are more susceptible. C fibers have no myelination, so the area of contact, that is concentration acting on the fibers, is less. So that is the reason he is giving in his book Hustic. But remember, absolute relationship between fiber size and anesthetic block does not exist. This is from the Collins. But the order of loss of sensation is fixed for all spinal anesthesia. So the first sensation lost is the vasomotor block. So there will be a dilatation of the skin vessels. So increased blood flow to the skin. Then block of the cold temperature. Now the patient feel a warmth due to the cutaneous vasodilatation. Then the temperature discrimination will be lost. Then slow pain will be lost. Then fast pain will be lost. Then tactile sensation. Then motor paralysis, pressure sensors, and the last one abolished is the proprioception and motion sense. Then how to test the level of the block? The sympathetic system can be tested by sympathogalvanic reflex. That is the skin resistance. From the skin resistance, they can assess the sympathetic block. The cold is assessed by the alcohol swab, and temperature, there is a temperature difference of 0.8 to 1.6 degree. The skin temperature is above the core temperature due to the vasodilatation. Then motor blockade, it is assessed by the Bromage scale. This is the Bromage scale 1, 2, 3, 4. 1 is complete block. 4 is the failed block. That is incomplete block. So the complete block, there is unable to move feet and ankle. So almost, that is 2. That is grade 2 is able to move his feet only the big toe. Partial block means just able to move and flex both. Sorry, just able to flex only the knees. But complete failure means he is able to flex knees, hip, and able to extend knees and hip. So coming to the spread of local anesthetics in the spinal CSF, Stout principle for spread of solution. So Stout has proposed here 7 points as a Stout principle for the spread of the solutions. So he says the height of anesthesia is directly proportional to the concentration of the local anesthetics and inversely proportional to the rapidity of the fixation of the anesthetics and directly proportional to the speed of injection and directly proportional to the volume of the fluid and inversely proportional to the spinal fluid pressure and directly proportional to the specific gravity for hyperbaric solution. In case of isobaric and hyperbaric solution, the extent depends on the position of the patient. Few points of the Stout principle is not proved subsequent experiments. So this is the 9th edition Miller. I have taken from 9th edition Miller. Here the distribution depends upon the factors they have mentioned is the more important factor, less important factor, and not important factor based on the drug factors, patient factor, and procedure factor. So most important factors that determine the distribution of the local anesthetics in the CSF is the dose and varicity of the drug, CSF volume, advanced age, pregnancy, patient position, and epidural injection after spinal anesthesia. The less important factors are volume of the local anesthetics, concentration, temperature of the injection, and viscosity. And patient factors, weight, height, spinal anatomy, intra-abdominal pressure, and procedural factors, the level of injection, the fluid current in the CSF, and the needle orifice and needle type. So these are the less important factors that determines the spread of local anesthetics in the CSF. So not at all important is the additives other than opioids and menopause and gender. So the another important factors that determines the spread of the local anesthetics in the CSF is the varicity. So what is density? What is specific gravity? What is varicity? So density is the mass per unit volume. Specific gravity is if you compare the density of one liquid to a standard liquid, that is water is taken as a standard liquid, specific gravity as 1. So if you compare the density of one liquid to the water, it is specific gravity. Suppose you compare local anesthetics density with the density of the CSF, which is called varicity. So specific gravity means water is 1, we are comparing with water. So baricity means CSF, it is 1. So we are comparing the local anesthetics with the CSF. So here these two drugs, tetracaine and lidocaine in 0.33% water and 0.5% in water, are density lower than the CSF. So it is called hypobaric. Here it is density similar to the CSF, so it is isobaric. Here density is higher than the CSF, so it is hyperbaric. So here a small demonstration of glass spine model by Dr. Lenny.
For the first part of the demonstration, I'm going to inject a solution made hyperbaric with dextrose and stained with waxylene rhodamine. And on this occasion, the patient is lying on her side.
So the patient is lying in the lateral side. He is injecting the hyperbaric solution.
Inject the solution, it cuts it for the nerves of the, take the needle out.
Now he is going to tilt the patient into the supine position.
And turn the patient onto her back. And the heavy solution runs in both directions, caudad and cephalad, in the subarachnoid space. What runs caudad is achieving nothing further in the way of a nerve block because the caudal equina has been cut off.
So the drug has descended to the caudal and also advanced to the cephalad direction up to the level of thoracic T5. Now he is going to tilt the patient head down. So what?
To the mid-thoracic region. Even if the patient is tipped head down, and this would be quite a steep head down tilt on a bed or table, the solution will only run another segment or two before it begins.
So he tilted the patient head down in the supine position. Now the cephalad direction, it moves 1 or 2 segments above, but it does not move above the T5 or T4. But now he is going to turn the patient to the lateral side and tilt the head down. You see.
To slow down again. On her side, but even a little bit head down, there is nothing to stop the solution running higher into the upper thoracic, cervical, and indeed even the intracranial subarachnoid space.
So this is more important. In lateral position, it may be a lateral or left lateral. So when you tilt head down, there is no protective mechanism of thoracic curvature in the lateral position. That will be lost. So you will get high spinal anesthesia even to the cervical region. That is more important. So when you put the patient head down, don't put in the lateral position. So now he is going to give the spinal anesthesia in the sitting position and turn the patient to the supine position.
For the first part of the demonstration, I'm going to inject a solution. For the next part of the demonstration, I'm going to inject a hyperbaric solution with a patient in the sitting position. And if you can inject very slowly, which sometimes is difficult, into the lowest sacral segments.
So it drips down to the caudal region.
The caudal equina. And this gives, if you inject just slightly quicker, which would be about L2 or thereabouts. But the local anesthetic moves very little up in the subarachnoid space, perhaps a segment or two.
So it is more concentrated in the caudal, so it is called saddle block. Now he is going to turn the patient to the supine.
Demonstration, we inject the solution, it cuts across the nerve roots in the caudal equina. And turn the patient onto her back. This would be wedged, of course, if it was a cesarean section. Once again,
please listen carefully what he says.
Local anesthetic runs both ways in the subarachnoid space. I think it's worth noticing that the dye in the caudal end of the sac here is quite intense, and this is because an unpredictably high proportion of the local anesthetic gets trapped in the caudad part of the lumbar convexity. But in the thoracic end, it once again runs down to the lower part of the thoracic concavity. But in this case, it is just possible that the spread of dye, you can see, is less intense. So although the block goes high enough, it may be a rather less intense block and may last less time.
So this is more important. When you put the patient in the sitting position and give spinal anesthesia with hyperbaric solution and put the patient at the supine, it drag on both sides, caudal and cephaloid. But the cephaloid, the intensity of block will be less compared to the give a spinal anesthesia given in the lateral position and turn to the patient to the supine. So the intensity of block will be less in the cephaloid regions. So the duration will be less. So whenever you give a spinal anesthesia for a cesarean section, it is okay. But when you are giving a spinal anesthesia in a sitting position for a hysterectomy, the cephaloid blockage will be less intense and the block duration will be likely to expire very early. So you have to keep this in mind. So next important factor that determines the spread of local anesthetic in the spinal canal is the volume of the CSF. So the CSF is secreted 0.4 ml per minute. So if you have lost 20 to 30 ml of CSF, it will be replaced just in 1 hour. There are 150 ml of cerebrospinal fluid in the vault. So it is only 25 to 30 ml is in the subarachnoid space. So anything that decreases the CSF volume in the vertebral column by your obesity, pregnancy, and increased abdominal pressure, this all cause the dilatation of the epidural vessels that compress the dura and reduces the spinal volume. That will produce higher block. But it is very difficult to predict the level of spinal anesthesia because of the wide variability of the CSF volume differs from individual to individuals. So it is a rough calculation. You can expect to find 1 ml of CSF for every vertical level above S2. Suppose mid lumbar L3, the volume will be 5 ml. So mid thoracic, the volume will be 15 ml, and foramen magnum, the volume will be 25 ml. So coming to the rate of injection, always you have to give a spinal anesthesia with a speed less than 0.5 ml per second. So the rate of injection and its correlation with the height of spinal anesthesia is unpredictable. So here, if you see this picture, here 1 ml is given 5 seconds. Here also 1 ml is given for 5 seconds. The mean level is T11. But here, the 1 ml is given for 5 seconds. Then 1 ml is given for 10 seconds. In this patient, the level is T9, but in this patient, it is T11. So it is unpredictable to assess the height with regard to the speed of injection. So coming to the barbotage, what is barbotage? It is a technique of mixing the local anesthetic and CSF and produce a turbulence in the spinal canal, thereby increasing the height of the spinal anesthesia. So while giving the spinal anesthesia, you have to withdraw some CSF into the syringe and mix thoroughly with the local anesthetics, and once again you inject into the spinal canal. So it will cause a turbulence in the CSF and the level of blockage will be much higher. So this is the dose, duration, and onset of local anesthetics. All of you know, bupivacaine has duration of 90 to 110 minutes and onset is 5 to 8 minutes. Lidocaine 60 to 70 minutes, onset is 3 to 5 minutes. So coming to the additives to the local anesthetics, you know the popular additive is the opioids. So opioids, how acts in the spinal canal. So there are 3 mechanisms. One is it acts on the dorsal horn opioid receptors. Second is through the CSF is spread to the cerebral opioid receptors and there it acts. And after systemic absorption, it acts and exhibits the systemic effects. So highly lipid soluble fentanyl and sufentanil, they are more rapid onset and shorter duration of action. If you know the potency compared to the intravenous, it is 10 to 20:1. Hydrophilic opioids are morphine, dimorphine, mepridine. They have highly slow on uptake and elimination is prolonged. So their potency is compared to the intravenous, it is 200 to 300:1. That means 1 to 5 milligram in the epidural, 100 mg to 300 mg in the intrathecal. So the vasoconstrictor, epinephrine and phenylephrine is used. They act through the alpha mediated vasoconstriction. So the uptake is reduced. So there is prolongation of the duration. It acts mainly along with tetrakine and little with lidocaine, but not much with bupivacaine, because bupivacaine has its own property of vasodilatation. Then alpha 2 agonists, clonidine and dexmedetomidine, they act on the prejunctional and post-junctional alpha receptors and the Horn cells. Then neostigmine, all of you know, it inhibits the breakdown of the acetylcholine. So there is accumulation of the acetylcholine. Acetylcholine is an anti-nociceptive. It also acts through the release of the nitric acid in the spinal cord. So other additives are midazolam, ketamine, adenosine, tramadol, magnesium, and non-steroidal anti-inflammatory drugs. So coming to the indications, so we have already seen upper abdominal surgery, lower abdominal surgery, lower limbs, and perineum. So the contraindications are, absolute contraindications are patient's refusal, coagulopathy, infection of the local site, severe hypovolemia and shock, increased ICT, and allergic to drugs, and severe AS in EMS. In 9th edition of Miller, they have mentioned itis stenosis and mitral stenosis in the relative contraindication. So every book says different relative contraindications. So uncooperative patient is relative contraindication. Pre-existing neurological deficit. If there is any pre-existing neurological deficit, like in polio, you have to mention the neurological deficit in the pre-spinal itself. So it will stand in the court of law. Then if there is a severe spinal deformity was once thought as a relative contraindication, but at the advent of ultrasound, it is no more contraindicated. Then infection at the site or at remote sepsis is also one of the relative contraindications. So the side effects, minor, moderate, major. So minor is nausea, vomiting, hypotension, shivering, transient, itching, and your urinary retention. Moderate is the failed spinal postdural puncture headache, and your major is the direct needle puncture or needle trauma to the nerves. Then infection, abscess, meningitis, and vertebral color hematoma. It is a dire emergency. Patient will go for paraplegia due to compression. Then spinal cord ischemia, Cauda-Eakin syndrome by the repeated administration of the local anesthetic in the spinal CSF, and also increased concentration, as in the case of continuous spinal anesthesia. So it is no more we are doing continuous spinal anesthesia. And arachnoiditis, the drug mostly causes the arachnoiditis, lignocaine. So we are not using lignocaine no more in the spinal anesthesia. Then peripheral nerve injury. Then coming to the total spinal anesthesia, cardiovascular collapse and death. So the technique of spinal puncture. Suppose your attender is available to help for giving spinal anesthesia. He must hold the patient in a fetus position, one hand on the head and one hand on the feet, and the patient should fold his leg and hold the knees with both hands, and the attender should give pressure with abdomen over the folded knee. So this is the spinal position with the help of an attender. Suppose the attender is not available, the patient should lie on his lateral side in fetal position by holding the flexed knee against the abdomen with his two hands. And the gender variability. So in female, the pelvis is broader than the shoulder, so the vertebral column likely to tilt towards the cephaloid direction. And in the male, the shoulder is broader than the pelvis, so the vertebral column likely to tilt towards the column. In sitting position, always give support to the legs. This is the jackknife position. It is used only for the hyperbaric solutions. So this is the recommendation for spinal anesthesia. This is nothing but how aseptic precautions we have to give the spinal anesthesia. So the layers we pass through when giving spinal anesthesia in the midline and paramedian approaches. In the midline, skin, subcutaneous tissue, and two ligaments, supraspinous ligament, interspinous ligament, and the ligament of flavum, then dura mater, subdural space, arachnoid mater, and subarachnoid space. In the paramedian approach, we will miss the supraspinatus ligament and interspinous ligament. So skin, subcutaneous tissue, paraspinous muscle, ligament of flavum, dura mater, subdural space, arachnoid mater, and subarachnoid space. So coming to the midline approach, the introducer is placed in the midline and it is in the cephaloid angle of 10 to 15 degree. The spinal needle is passed through the introducer. Once the spinal needle passes through the durameter, you can feel a pop. When the pop is felt, you have to remove the stillet and watch for the free flow of the CSF. You have to wait for 5 to 10 seconds because nowadays we are using only smaller size needles of 26 to 29 gauge. Suppose there is no free flow of CSF, you just rotate the needle for 90 degrees. Those are the problems encountered in giving spinal anesthesia. So this problem is discussed in Collins, in other books. Suppose you contact bone first, then you try to imagine what is the depth of the contact of bone. Then you withdraw the needle up to the skin and redirect. Suppose once again you hit on the bone. Suppose the depth is greater than the previous one, you are likely to hit the inferior spinous process. You have to redirect to the cephaloid. Suppose the depth is smaller than the previous one, the first one, then you have to imagine that you are likely to hit the superior articular surface. Then you have to tilt the caudal. So this is tips given in the Collins. Every time you have to withdraw the needle to the skin for redirection. So the paresthesia, suppose you felt paresthesia giving during spinal anesthesia, what you have to do? You remove the stillet. Suppose there is no CSF flowing through the needle, you are likely hit the spinal nerve in the epidural space. You redirect the needle. Suppose you felt the paresthesia and you remove the stillet and there is a free flow of CSF, then you are likely hit the nerve in the subarachnoid space. You rotate the needle and give spinal anesthesia, local anesthetics. Suppose while giving the local anesthetics, patient is having any excruciating pain, then you should not give the drug. You have to withdraw the needle. The needle tip is inside the nerve. So coming to the lateral approach, so you first palpate the that is your interlaminar space and infiltrate 1 centimeter lateral to the superior aspect of the inferior spinous process. Then introduce your introducer and spinal needle in the medial and cephaloid direction. Suppose you hit on the lamina, you walk over the lamina and enter the subarachnoid space. The only resistance you felt here is the ligament of flavor. So this is the Taylor approach. Here, 1 centimeter medial and inferior to the posterior superior iliac spine, your needle should be introduced in a cephaloid direction of 45 to 55 degree medially. So you are likely to enter the largest interlaminar space of L5 and S1. And after inserting the needle, the first resistance you felt here is the ligament of flavor. So this is the continuous catheter technique. Here, first you have to introduce the Tuhi needle, that is sheath over the Tuhi needle. So once you introduce the Tuhi needle and identify the epidural space, then you introduce the spinal needle. The spinal needle also sheath over the needle. So if you enter into the spinal canal, you remove the stillet and see the free flow of CSF. Now you thread your cannula through this spinal sheath. You can remove the epidural sheath also. So you can fix along with the spinal sheath or your spinal cannula. But remember to label it is a intraspinal catheter. Otherwise, you are likely to inject the epidural dose inadvertently into the spinal canal and end up in high spinal anesthesia. So the equipment for spinal anesthesia. So all of you know, nowadays we are using only spinal needles with removable stillet. The advantage of a stillet is it prevents the skin and adipose tissue being carried to the subarachnoid space. So there are two types of needles, all of you know, it is pencil point needle and cutting bevels. So pencil point needles are Spority and Whitaker. They have a rounded non-cutting bevel, but the opening is 2 to 4 mm from the tip of the needle. The cutting needle is the Quincke and Pitkin. In Quincke, it is a medium length cutting needle. Pitkin is a short bevel needle. And Greeny spiny needle is a rounded body point and rounded non-cutting bevel. The advantage of pencil point is you can better feel the tactile sensation and the incidence of post-dural puncture headache is less. When you use bevel needle, your bevel should be longitudinal to the supraspinous ligaments because it will split the ligaments rather than cutting the ligaments to reduce the incidence of the PDPH. So this is the Quincke needle. It is a medium cutting needle. This is the Spority pencil point needle. the opening is 2 to 4 mm from the tip. Then Whittaker is the pencil point needle, and Greeny is the round cutting, non-cutting bevel, and Pitkin is similar to Quincke cutting needle, but the short cutting bevel. Bevel is very short. This is the 2E needle. So the pharmacology, pharmacodynamics. So far we have seen the pharmacokinetics of the local anesthetics. Now we are going to see pharmacodynamics of the spinal anesthesia. So all of you know it will induce hypotension because of the preganglionic sympathetic nerve block and direct circulatory effects, relative adrenal insufficiency, skeletal muscle paralysis, and ascending medullary vasomotor nerve block, and also concurrent respiratory insufficiency. So coming to the hypotension, there are two schools of thought. One is preload theory, another is the afterload theory. In preload theory, what they say is 80% of the circulating blood volume is in the venous side. So when there is a vasodilatation, there is stasis of the blood in the venous system. So venous return reduced, so your cardiac output reduced, so your blood pressure reduced. But afterload theory, what they say is it reduces the systemic vascular resistance, and there is vasodilatation of the arterial side. So the cardiac output initially increases, and the resistance, systemic vascular resistance is reduced. So your blood pressure, that is afterload, is reduced. So this is the afterload theory. So this is an example. This is a beaker with fluid. You remember this is a blood vessel with blood. After spinal anesthesia, there is a vasodilatation. So the beaker size is increased. So the level of the fluid falls down. So the pressure at the bottom of the beaker also falls. Suppose if you want to increase the pressure at the bottom of the beaker, what you have to do? You have to pour more water. So the water column rises means the pressure at the bottom of the beaker will rise. Likewise, you can reduce the diameter of the beaker. So the water level will increase. So the pressure at the bottom of the beaker will be also increased. So the treatment is you give either fluid or vasoconstrictors. So this is minimum systemic filling pressure. What do you mean minimum systemic filling pressure? Suppose you imagine your heart stops. Your vascular system is filled with certain amount of the blood, and they exert pressure. That pressure is called minimum systemic filling pressure. It is about 7 mm of mercury. So the volume is called unstressed volume. So suppose you add more fluid or blood over this minimum systemic filling pressure, it is called stressed volume. This stressed volume causes return of the fluid, that is return of the blood to the right atrium, and it increases the cardiac output. So in spinal anesthesia, all the volume available is converted into unstressed volume. Now you have to add more fluids, means you increase the stress volume, that increases the venous return and increases the cardiac output. Or otherwise you give vasoconstriction. If you give vasoconstriction, the unstressed volume is converted to stress volume, that increases the venous return and that increases the cardiac output. So this is the mechanism of treating the post-spinal hypotension. So there are 4 receptors come into play in spinal anesthesia. So what is baroreceptors? All of you know baroreceptors are situated in the carotid bodies, and cranial nerves 9 and 10 is the efferent. And when there is a hypotension, there is less pressure on these stretch receptors. So your decreased sympathetic activity. So your vagal nerve is less stimulated. So simultaneously sympathetic overactivity causes increased heart rate, increased force of contraction, and vasoconstriction, thereby increasing the blood pressure. Remember, this baroreceptors reflexes come into play when there is a hypotension. And there are some other reflexes are there: Bainbridge reflex, reverse Bainbridge reflex, and Basalt-Gerry's reflex. So what do you mean by Bainbridge reflex? In the laboratory, they have cannulated dog's superior vena cava, and they have given 1 liter of saline very fast, and they have noted there is a tachycardia. So it is due to the stretch receptors or mechanoreceptors that present in the right atrial wall and cavoatrial junctions. When it gets stimulated, it inhibits the parasympathetic stimuli, and it increases the sympathetic stimuli and produces tachycardia. So coming to the reverse Bainbridge reflex. So whenever there is a high spinal anesthesia occurs, that is involving the T1 to T6, that is cardiac sympathetic fibers, there will be bradycardia. But the bradycardia occur even in spinal anesthesia where the height of block is less than T6, less than T6, they have noticed bradycardia. So in these patients, when they raise the legs, venous return increased and the bradycardia is abolished. Suppose the bradycardia occurred in the low spinal anesthesia is due to the blockage of the thoracic sympathetic fibers. The raise of the legs will not abolish the bradycardia. So they thought it is maybe due to some other receptors. So it is nothing but the same vein bridge receptors situated in the atrium that is less stimulated. So your parasympathetic stimulation get activated and that produces bradycardia. But remember, this reverse brain bridge reflex occurs only in the spinal anesthesia, and your brain bridge reflex comes into play only when there is volume overload. So coming to the Basal-Gerry's reflex, it occurs in the spinal anesthesia. So the receptors are present in the left ventricle. It occurs when during spinal anesthesia, when there is a hemorrhagic shock, that is volume is depleted and there is a hemorrhagic shock, this reflex come into play. So the receptors are present in the left ventricular wall and unmyelinated vagal afferent type C fibers through which it passes through the medullary vasomotor center and stimulate the parasympathetic tone and produces bradycardia. So it is a triad of bradycardia, hypotension, and peripheral vasodilatation. So remember, it comes into play during spinal anesthesia when there is hemorrhagic loss of blood. So the risk factors associated with hypotension. So what are the risk factors that aggravate the hypotension after spinal anesthesia is your hypovolemia, pre-existing hypovolemia, your preoperative hypertension. Suppose the patient has a preoperative hypertension, they will have a active sympathetic tone and their circulating blood volume will be reduced. So after spinal anesthesia, when there is a sympathetic block and vasodilatation, they will likely to get severe hypotension. Then high sensory nerve block, so more sympathetic blockade, age older than 40 years, obesity, and combined spinal and general anesthesia. Remember, during spinal anesthesia, when the tone of the sympathetic tone is lost in the arteries below the block, there will be a compensatory vasoconstriction above the block, that is in the upper limb. So in general anesthesia, what happens? It suppresses the compensatory vasoconstriction in the upper limb. So you are likely to go for a high spinal hypotension. So then chronic alcohol consumption is interesting. Patients with chronic alcohol consumption have prone for more hypotension. Then elevated BMI, then urgency of the surgery. So they have done a retrospective analysis of more than 300 patients and they analyzed what is the contributing factor for the increased occurrence of the post-spinal hypotension. So interestingly, the chronic alcohol consumption, yes, there is increase in incidence, 14% compared to the 5%. In urgency, in emergency surgery, there is high incidence of hypotension, 11.6% compared to 5.2%. And previous history of hypertension, yes, previous history of hypertension, 9.8% compared to 3.9% in the non-hypertensive patients. So ASA physical status, first is 3% and ASA risk 4 is 9.5%. But interestingly, they have analyzed the hypotension between the surgical department. If you see trauma, ortho, urology, general surgery, gynecology, and others, the hypotension is less in urology department cases and more in the gynecology cases. That is 11.8%. So coming to the management of the hypotension after spinal anesthesia. So management is non-pharmacological method. You have to position the patient, trundle block position, leg compression, uterine displacement. Prevention is preloading with colloids, co-loading with crystalloids, lower limb compression. You give low dose of local anesthetics by adding additives. Treatment, you give vasopressors and fluids. Phenylephrine is given when there is a hypotension tachycardia. Ephedrine, if there is hypotension with bradycardia. The problem with the ephedrine is tachyphylaxis and fetal acidosis. Then whenever there is bradycardia, you give atropine, ephedrine, or epinephrine, any one you can give. When there is a severe hypotension with bradycardia, you go for directly to the epinephrine. So this is the regimes of how to give phenylephrine. So phenylephrine comes with 10 milligram. So you add 10 milligram to 100 ml normal saline, get 1 ml. So it contains 0.1 milligram per ml. Then you start a infusion of 60 ml per hour. there are three regimes available for giving phenylephrine. That is on and off infusion regime. Here, after giving spinal anesthesia, you start the first 2 minutes. You run the infusion of 60 ml per hour. You have to stop this infusion only when the systolic pressure is more than 120% of the baseline. Then after the uterine incision, this is the regime is for the obstetric spinal anesthesia. So the after second minute until the time of uterine incision, you keep on flowing this infusion of 60 ml per hour. It should be stopped when the baseline, the pressure systolic BP is above the baseline. So this is the second method, is the sliding scale method. Here increase the infusion rate according to the systolic BP from 0 to 60 ml per hour. Coming to the bolus regime, this is what we are doing. So you have to prepare a solution of 0.1 milligram, that is 100 mg per ml. How to prepare? You dilute the 10 milligram to 10 ml, then take 1 ml from the 10 ml, then dilute to 10 ml. So the resultant solution will have 0.1 milligram, that is 100 mg per ml. So that you can give whenever there is a fall in BP. So there are so many ways to prevent the spinal hypertension. So they have done a systematic review in the Cochrane library. They have analyzed fluid, drugs, and physical methods, and they come to a conclusion: no single or combined prophylactic intervention avoids the post-spinal hypertension. So you can 100% you cannot avoid post-spinal hypertension by your preventive measures. So this is the interesting topics. This is for the consultants. So this is the supine hypotension syndrome of pregnancy is we encounter in the obstetric spinal anesthesia. So the textbook says 15-degree tilt, there will be relief of the IVC and aorta. But in a MRI, if you see at L2, L3 level, 15-degree, there is femoral artery, aorta is released, but your your IVC is still compressed. See, your IVC is still compressed in 15-degree tilt. In 30-degree tilt only, your IVC compression is relieved. So whether 15-degree tilt is possible, that is 30-degree tilt is possible in your practice. So we have done one experiment. So for 15-degree tilt, we need one person to hold the patient on the table. For 30-degree tilt, we need 3 persons to hold the patient on the table. So 30-degree tilt is not at all possible in our practical purposes. So imagine what will be the pelvic wedge tilt. So interestingly, they have an article was published in Anaesthesia Analgesia regarding the aortocaval compression, whether it is the time to revisit. Here they says 15-degree tilt never achieved in practice. And out of 100 patients, 75 patients only they have kept tilted for 15-degree by 21 anesthetists. And only 3% of the obstetricians tolerated 15-degree tilt. 76% of the patients feel discomfort as if they are feeling sliding or toppling from the table. So the left uterine displacement does not appear to be practical in our practice. So what is going to be the take-home message? For practitioners, what the journal says, whenever there is a normovolemic patient, you need not keep the tilt. When there is a hypovolemic patient, you always keep a pelvic tilt. So this is the journal says. But for practical purposes, I am doing a practice of keeping the pelvic tilt for all my patients, and I have reduced my vasopressor usage less than 50%. So my advice to postgraduate is always keep pelvic tilt, whether it is useful or not. Suppose it may be useful for one patient out of 100, but you are likely to save that one patient. So you always keep tilt of the pelvic tilt as much as possible. For practitioners, it is up to you to take the message, whether you can tilt the pelvic tilt for normovolemic, hypovolemic patient, and you can avoid the tilt for normovolemic patient. How to identify the normovolemic, hypovolemic patient? My simple advice is you see the catheter. In catheter, if you have a concentrated urine, the patient may be in a hypovolemia. If the catheter is clear urine, it is a subjective assessment only. It is not a evidence-based assessment. Then coming to this tilt, what they say, systemic review says. So there is one systematic review published in the Cochrane Library. It says the maternal position during cesarean section for prevention of maternal and neonatal complications. They conclude that there is a limited evidence to support or clearly disprove the value of using tilting. So there is no evidence to support or disprove. So it is up to you to decide. So coming to this, another school of thought, they says the hypotension is due to the reduction in the afterload. So they says the treatment should be, vasopressor should be the primary therapeutic option, and your fluids will be restricted only to the volume depleted patients or in the preloading or co-loading. What they say is, if you give fluids, it will reduce the viscosity and reduces the systemic vascular resistance, and it will aggravate the hypotension. So first line of the treatment is vasopressor. If atropine and ephedrine is given for bradycardia. So other effect of respiratory effect, there is no much effect because the arterial blood gas remains normal. The inspiration is minimally affected, but all patients feel dyspnea after spinal anesthesia. Why they feel dyspnea? Because their inability to feel the chest wall movement during respiration, they feel as if they are having a dyspnea, difficulty in breathing. So in high spinal anesthesia, what happens? It paralyzes the accessory muscles of respiration. So you are likely to get expiratory reserve volume decreased. Your peak expiratory flow is decreased and maximum minute ventilation is decreased. So in obstructive COPD patients, you have to be careful when there is a high spinal anesthesia. So gastrointestinal system, because sympathetic blockade, unopposed parasympathetic blockade increases the secretion and causes sphincter relaxation and increases peristalsis and lead to nausea. And your hypotension is also induced by the ischemia-induced serotonin release and emetogenic substances. And hepatic renal blood flow is not at all affected. So coming to the last portion, that is clinical situation encountered in our practice of spinal anesthesia. So in a case of a obstetric spinal anesthesia, you have given the spinal anesthesia, but it is not taken. So what to do? Suppose if it is a single shot spinal, there is inadequate spinal anesthesia before incision of the skin incision, then you convert it to the GA or combined spinal epidural. Why combined spinal epidural? You have already given local anesthetic in the CSF. So if you repeat spinal anesthesia, you are likely to give a large dose of drugs in the spinal anesthesia and end up in high spinal anesthesia. So if you go for combined spinal anesthesia, you give more drugs on the epidural and you likely to give a little drugs in the CSF. So high doses can be avoided in the spinal anesthesia. So you go for GA or combined spinal anesthesia. So for every repeat spinal, you better go for a combined spinal epidural. Then suppose patient feels pain before opening the peritoneum, you convert to the GA. Suppose if the patient feels pain after delivery of the patient, after opening of the peritoneum, you convert to GA or go for a adjuvant, giving adjuvants like fentanyl, midazolam and ketamine, but never administer propofol and thiopurine without securing the ARV. So how often you have to check the blood pressure after obstetric spinal? So every minute you have to check the blood pressure until the delivery of the fetus, because your uterus has no auto-regulation. So the dose of the local anesthetic is reduced in pregnancy. Why? So there are two mechanisms. I already told you, the aorta cable compression, the IVC is obstructed. So there is dilatation of the epidural vessels that compress the dura and reduces the spinal volume of the CSF. So small drugs cause high spinal blockade. And another reason is there is increased fat in the epidural that also compresses the dura and reduces the volume of the CSF in the lumbar region and increases the height of the spinal anesthesia. But they have noted the requirement of local anesthetics in pregnancy is well noted before 20 weeks of pregnancy, because the supine hypotension syndrome comes into exist after 20 weeks of pregnancy. But the requirement is still reduced before 20 weeks of pregnancy. So what is the reason? So there are two reasons, biochemical and hormonal. So circulating progesterone level is high, so that alters the receptor activity, modulation of the sodium channels, and also alter the permeability of the neuronal membrane. And your biochemical, so it decreases the CSF specific gravity. In pregnancy, the CSF specific gravity is low, and there is an acid-base changes in the CSF. So that is the two reasons for the increased sensitivity of the local anesthetics in pregnancy that reduces the required dose to 40%. But when it comes return to the normal, it is 8 to 24 hours in the postmortem. In some books says it is 48 hours. So coming to the high spinal and total spinal. So we are often using the word high spinal, total spinal. So when it is called high spinal, suppose it affects the thoracic T1 to T4, it affects the cardiac sympathetic fibers, there will be hypotension of the bradycardia. It is high spinal anesthesia. Suppose it affects C6 and C8, it affects hands and arms, there will be paresthesia, numbness of the hands and weakness of the hands and arms, and there will be shortness of the breath due to the accessory muscles of respiration is lost. Suppose it blocks C3 and 5, diaphragm and shoulder, there will be shoulder weakness. Whenever there is a shoulder weakness, the patient complains, beware of the diaphragm paralysis also. So there will be hypoventilation, desaturation, and respiratory arrest. If it is extended into the intracranial spread, it is called total spinal anesthesia. So a brainstem is affected where there is vasomotor center is there. So you will have slurred speech, sedation, and loss of consciousness. When the patient go for loss of consciousness due to intracranial spread, it is called total spinal anesthesia. So whenever there is a high spinal or total spinal anesthesia, look for the signs and symptoms. Then you call for help. Then you immediate management should be, if there is a continuous flow of the epidural infusion for your labor analgesia, first you have to stop that infusion. Then you can give a reverse Trendelenburg. Reverse Trendelenburg is to restrict the upward spread of the local anesthetic in the CSF. Then give high flow oxygen. If there is severe hypotension, you give Trendelenburg tilt also. Then you have to assess ABC, airway, breathing, circulation. Suppose the patient is unconscious and there is severe hypotension, you have to intubate, ventilate the patient, and you have to plan for emergency LSCs. Suppose the patient is conscious and circulation only compromised, then you go for a left lateral tilt and also go for the fluid and vasopressors. So this is the signs and symptoms you have to look for. That is hypotension, bradycardia, respiratory compromise, apnea, reduced oxygen saturation, slurring of the speech, and cardiac arrest. Then neurological symptoms. So bradycardia, treat with vagolytic sympathomimetic. Hypotension, your vasopressors. Respiratory dysfunction, intubate and ventilate. Loss of consciousness, secure airway, and supportive mixtures. So always you talk about the unilateral spinal anesthesia. So how to give unilateral spinal anesthesia? So you have to be concentrate on the type and gauge of the needle, density of the local anesthetics, and position of the patient, and speed of administration of the solution, the dose, concentration, volume. You have to concentrate on the dose, concentration, volume of the local anesthetics we are going to inject. So slow administration is a must with low doses, and hyperbaric and hyperbaric solution can be used. So suppose you are using hyperbaric solution, you keep the affected part dependent. Hyperbaric, you keep the affected part non-dependent. Then keep the lateral decubitus position for 15 to 30 minutes. When using hyperbaric, 0.15% bupivacaine, the unilateral block prolongs according to the dose you used. 4.5 milligram for 2 hours, 6 milligram 2 hours 15 minutes, 7.5 milligram 3 hours. Like that, the duration will be increased depending upon the dose. So how to prepare a hypobaric 0.15% bupivacaine? Take 1.5 ml of the 0.5% hyperbaric bupivacaine. You add distilled water 3.5 ml, total 5 ml. So the total 5 ml contains 7.5 milligram. Each ml contains 1.5 milligram. Suppose you want 4.5 milligram, you take 3 ml. If you want 6 milligram, take 4 ml. If you want 7.5 milligram, you take 5 ml. So this is the anticoagulated patients. For unfractured heparin, you need not wait for 5,000 units. If you are more than 5,000 units BD, you can wait for 4 hours or 2 hours. Then you are using low molecular weight heparin. Prophylactic dose, you have to wait for 12 hours. Therapeutic dose, you have to wait 24 hours. For aspirin, you need not withhold the aspirin for giving spinal anesthesia. Warfarin, you have to wait for 3 to 5 days when the INR falls below 1.3. So coming to the last slide. So nowadays, everybody is talking about thoracic spinal anesthesia. So what do you think about thoracic spinal anesthesia? It is an unorthodox technique infrequently used. So it is not mentioned in any textbook. So I am taking a class to the postgraduates. So I am using the word unorthodox technique infrequently used because I have to go through the textbook teaching only. So the textbook teaching is you have to give spinal anesthesia only below the cauda equina, but they are giving spinal anesthesia in the thoracic region. How is it possible? So if you see the MRI, the spinal cord is very close to the posterior dura in the lumbar region, and it is close to the anterior dura in the thoracic region. There is a space in the posterior dura for your to accommodate your spinal needle tip. So in the anteriorly, in the thoracic region, there is the 9.5 to 1.8 mm space is available in the thoracic region. So whenever you use thoracic spinal, you better to use a cutting needle rather than your pencil point needle, because the pencil point needle, the hole is 2 to 4 mm distal to the tip. So when you observe the flow of CSF in the pencil point needle, your tip would have already pierced the spinal cord. So cutting needle, once it enters into the spinal canal, you can see the flow of CSF. So what is the advice of using this thoracic spinal anesthesia? Since there is absence of large trials, only small cohort studies and multiple case reports are available. It may be considered safe and feasible and effective only in the case of high-risk patients, not in elective patients. So these are the doses and level and for the surgeries of breast surgeries, gastrectomy, laparoscopic cholecystectomy, and so with that, we come to the end of my presentation. Thank you. So I have taken too much of time. Sorry, Subarachnoid sir.
Sir, it is not too much of time. It is very difficult to find such a topic in a short time. It is very difficult for the postgraduates to get this amount of material also, sir. So it will be worthwhile for them. We shall see a few questions, sir. The first question is putting spinal in prone position and keeping the position in the prone itself. How does the local anesthetic spread in that vertebral column?
So it is opposite to the supine. It has a level of spread is, if you are using hyperbaric solution, the level is similar to the keeping the patient supine after giving lateral spinal anesthesia. But they say that it is likely to cause more block in the anterior nerve root. What do you think, Selvakumar sir? Keeping the spinal in, giving spinal in the prone position. You unmute yourselves. Unmute yourselves, sir. Selvakumar sir.
Yeah, prone position, spinal and prone position. It is given during the laminectomy surgery. Anesthetist, generally, we don't prefer spinal for prone position for spinal. When laminectomy surgeries are done and prone, already given conventionally spinal, turn the patient in prone, surgery is going on. To extend the anesthesia, some people are giving spinal in prone position itself. Just puncture the dura and give the drug. So naturally, as the curvature decides the lumbar lordosis and curvature decides the spread, we don't know how the patient is positioned prone, what are the supports given, and generally it should not influence too much. I have seen people giving in prone during laminectomy, the spread doesn't go to the higher regions. So it restricts itself to the lumbar and lower thoracic. But from the beginning, you want to give it in prone position. I don't know what is the situation forces you to give the spinal in prone. During laminectomy, I have seen, and it doesn't affect anything. The same thing.
Subarachnoid sir, your opinion also.
From my professors, I've heard people giving spinal in prone position hyperbaric solutions, sir. But in the modern practice, I don't think there's no indication to give a prone position spinal, sir. They have used hyperbaric solution and they have done perineal surgeries with that in jackknife position. I've heard from my professors, but I've never seen one, sir. Let us move on to next question, sir. How about the presence of peripheral neuropathy? Is it a contraindication for subarachnoid block?
It's never a contraindication. Suppose there is a nerve block, there is no, sorry. Suppose there is a pre-existing neurological deficit, you get a neurologist opinion and get down the neurological deficit at present before the spinal anesthesia. So they can compare the deficiency in the neurological deficit can be compared after spinal anesthesia. If there is the same, there is no problem. So you can stand in the court of law also. What do you think, Suleiman sir? So what's your opinion, sir? Sir?
I think you have answered it, sir. It's not a contradiction at all.
Yes.
Can reverse brain bridge reflex be prevented with co-loading or preloading of fluids, sir?
So it acts only when there is a hypovolemia. So when there is no normovolemia by your preloading, it will not occur. So the concept is the same. If there is a volume reduced, so there is a receptor stimulation is reduced. So there is a bradycardia. So if the receptor stimulation is not there by your preloading or co-loading, then it will not occur.
Likewise, sometimes I have seen, sir, when there is hypotension treating with the pure vasopressor, once the BP comes up, reflex bradycardia sometimes happens. Like when we use phenylephrine, sometimes the rate goes down, sir. I've not seen with ephedrine bradycardia, but I've seen with phenylephrine, sir.
So it is mainly maybe due to the arterial side. It is a baroreceptors reflex. So the receptors there, you must know there are receptors, certain receptors in the venous side, which helps in the case of hypertension. There are some receptors in the arterial side. Only the baroreceptor receptors in the arterial side. On the venous side, the receptors are in the left atrium, left ventricle, right atrium, and right ventricle. So the vein bridge and reverse bridge. So whenever there is a increase in the sudden increase in the BP, it may be due to the baroreceptor reflex causing reflex bradycardia. Mostly you note in the mephedrine.
Yes, sir. Prema ma'am has asked a question on how to differentiate between a high spinal and a subdural injection, and what is the incidence of a subdural injection after spinal anesthesia, sir? Actually,
I have included 2 slides for subdural anesthesia because it is not in the epidural class. I have omitted that. So subdural anesthesia, there is criteria, Lubinov criteria, I think. Sir, there is a Lubinov criteria that is 2 major, 2 minor. So the onset must be delayed and the more sensory than the motor. So there are certain criteria for the Lubinov criteria. So if it fulfills the Lubinov criteria, so the level of blockade will be disproportionate, very high, and it is mostly on the sensory rather than the motor. Onset will be delayed. So this is the criteria for subdural anesthesia.
One last question, sir. Is it advisable to go for a second time spinal anesthesia when the first spinal anesthesia fails?
I already told, if you are going for second spinal, you are likely to, suppose that most of the drugs in the previous spinal is deposited in the CSF, you are likely to increase the dose, volume, concentration of the local anesthetic in the CSF. So better, the advice is go for combined spinal anesthesia, combined spinal epidural. So give drugs, some drugs in the epidural, give low drugs in the spinal canal. So even though your previous drugs is available in the CSF, you are likely to increase the therapy, that is toxic dose less. So that is the advice.
Okay, I think the questions are all. Sir, how to give ephedrine for hypotension, when to repeat and how much to give, sir?
How to give?
Ephedrine for hypotension, and how when to repeat and how much to give, sir?
So it's you take 30 milligram, dilute to 5 milligram, then you give 6 milligram in graded dose. That is the thing we are using for a long time. So ephedrine is one of the drugs that tachyphylaxis occurs very early. You know what is the reason? So it acts through the VMAT, that is vesicle monoamine transport. It acts as a substrate of noradrenaline. So it releases noradrenaline from the receptors. It is an indirect action. So it acts as a substrate of noradrenaline and releases noradrenaline into circulation. So the VMAT transport, that is T1 and 2 is there. So one is saturated quick. So the ephedrine loss is the effect. So nowadays we are going better for noradrenaline infusion also. So it acts through the noradrenaline, your ephedrine and your mephedrine. That is a long topic. Yeah, we can discuss in that.
Yes, sir. The time is up, sir. Can we have a question or we'll wind up, sir?
Okay, sir. Thank you.
Thank you, sir.
For wonderful.
Very excellent day today, sir. Both the history of anesthesia by Selvakumar, sir, and your spinal anesthesia. I am sure the first year for the postgraduates will be benefited a lot because these two topics, if they start reading, it will take 1 month of the time. We have given them in the period of 2 hours. So we'll upload the YouTube link soon, and you will be able to again and again revise it and take it into your mind. Next week we will meet with another interesting session with physiology and anatomy of pain and pharmacology of opioids. Until then, see you all. Thank you.
Thank you. Thank you, Evanologist. Thank you.
Thank you.
You can wind up. Thank you.